Hello, everyone. My name is Jessica Reed. I'm a consultant here at Qualidigm, and on behalf of the Maine Lung Cancer Coalition, we are so excited to invite you today to join us for our webinar, Meeting People Where They Are At, Community Health Workers and Lung Cancer Prevention. It's from noon to 1 today, and our speakers are Ann Connors and Mark Bourassa. Next slide. I would like to extend and acknowledge a thank you and acknowledgement for our funders for the Maine Lung Cancer Coalition in this webinar today, the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, the Maine Economic Improvement Fund, and Anthem Blue Cross Blue Shield. Just some important webinar notes to quickly review. You are in listen-only mode. Please use the chat feature to ask any questions or make any comments during the presentation. We're going to hold the questions until the end, and then we'll be happy to answer those. Any that we do not have time to answer, we will put into a Q&A document and send that out for any that we don't have time to answer. The video screen size and location is adjustable by clicking in the top corner of the boxes and dragging. We will have polling questions, which we're very excited about throughout this presentation, and we'll walk you through submitting your answers at that time. If you're joining by phone or with others on the same computer, it's important that you enter your information into the chat window or send your name and email to info@qualidigm.org. For today, we are the available CME, and our disclosure is today's speakers do not have any relevant financial relationships with the manufacturers of any commercial product or products and or provider of commercial services discussed in the CME activity. CME will be available for participants who have signed into the live webinar. If there are multiple people at one computer, we ask that you please type your name and email addresses into the chat box for our attendance records, and we can make sure that we are able to get the CME material to you. We do not have a separate nursing CEUs, but you can get a CME certificate. Once the webinar is ended, you'll get a pop-up screen that will direct you to the survey. So a little different with that. You may have seen that pop-up screen when you first joined the webinar. That may still be open on your screen. If you have clicked out of that, no worries at all. We're going to put the link into the chat box, so you can do that at the end. And also tomorrow, we're going to be sending you out a thank you email for joining us, the slide deck, and we'll put a URL for the CME into that email as well. So for the CME documentation process, you'll be able to immediately download your CME certificate at the last page of the survey. Please contact Mary Milam at the address here if you have any questions or problems when you download the document. So today, let's get started. So again, meeting people where they are at, community health workers, and lung cancer prevention. I'm so excited to introduce Ann Connors and Mark Bourassa. Ann Connors is a program manager at Maine General Health, where she focuses on chronic disease and cancer prevention. She has 20 years of experience in engaging with vulnerable populations to improve health outcomes and enhance quality of life. Mark Bourassa is our second presenter today, and he has around 2 years of experience in lung cancer prevention. Previously, he worked for 14 years in the banking industry, but he finds this so much more fulfilling. He can relate to the patients he contacts regarding tobacco cessation due to personal life experiences. He was a heavy smoker and lost his wife to lung cancer. Mr. Bourassa did not go looking for this job, he says, it found him. He says he found his calling because there is no more joy than to help someone else out of the addiction to tobacco. So at this point, Ann and Mark, we're going to turn the webinar over to you.
Thank you so much, Jessica and Morgan, for all your help with this webinar. We're really thrilled to be here today, and we really want to thank everybody who has joined us on the webinar when it's a gorgeous day and you could be having your lunch outside. So thank you for joining us. Today's learning objectives, we hope by the end of this webinar you'll be able to define the role of a community health worker on a healthcare team, describe 2 community health worker engagement techniques to reach the at-risk vulnerable population, and be able to describe a workflow in lung cancer prevention. So we're going to start with a poll question and ask if you're familiar with the term community health worker. And I'd also like to ask if you've heard any other term for community health worker, if you could type it into the chat box.
All right, everyone, I've launched the polling question. So if you'll just select your answer and then hit submit within the box so we can make sure to capture everyone's answers. And it actually looks like everyone's already responded. So thank you for being so timely. I'll go ahead and end the poll. And Anne, you should be able to see the results now.
I do, and we have an advanced group here today. 100% have heard the term community health worker, so everybody gets an A+. Did anybody chat any terms into the chat box? Let me just check that. So yes, somebody's chatted in community health outreach worker. 2 people chatted that in, and some other, that's right. That's what the Portland Public Health Department calls their community health workers. Promotoras is another term. You may have also heard about peer support, outreach workers, or navigators. So at Maine General, we use the widely accepted American Public Health Association definition of community health workers. So community health workers are really frontline public health workers. They're trusted members of their communities who have an unusually close understanding of those communities and of the resources and needs available, or the resources available and the needs in those communities. And because of this trusting relationship, community health workers are able to engage people, to improve their health, to access health care, to have a better quality of life. And, you know, the ultimate goal of having a community health worker is that you improve both individual and community capacity for better health outcomes and quality of life. You know, the goal is not that a community health worker would follow somebody all of their life, but that individual, because of intervention from a community health worker, would become more self-sufficient. During this webinar, we're really happy to share 4 years of work that we've done with community health workers and lung cancer risk reduction. For this project, we developed our own definition of community health workers that really fits within the American Public Health Association definition. So we define community health workers as an extension of the healthcare team who are trained in motivational interviewing, workflow implementation, and patient engagement, and that their lived experience and community knowledge allows them to form a bond with patients, to engage them and increase their access, you know, most critically by reducing barriers. And we use this definition not only to guide our work, to know, you know, what we were about, but also in some formal processes such as our institutional review board applications. So now we go to another poll question. Does your organization use community health workers?
So I just launched the poll, so go ahead and select your answers and hit submit again. All right, and it looks like everyone's answered again, so I'm going to go ahead and close the poll, and I have shared the results.
So yeah, so it looks like we have a really healthy component of people on the call that their organization does use community health workers, so that's 59% of people, and no is 41% of people. So it's great that organizations are using community health workers, and then we hope that, you know, some of the things we'll share on this call will allow those who aren't to articulate the value to the systems that they're working in. So now that we've had the 2 definitions of community health worker, we're going to have you meet a real live community health worker, and that's Mark Bourassa. Mark, would you like to introduce yourself?
Hi, yeah, I'm Mark Bourassa. I've been a community health worker now for 2.5 years, a little better than that. It's very rewarding what I do, and it's just getting a feel for where a patient is at and being able to relate back and forth between them and either their provider or some function that they require. It's a very, very fulfilling job.
We'll hear more from Mark about some of the unique things he brings to the table later. Just to review some of the skills, the really critical skills that community health workers bring to the table. One is communication, the ability to meet people where they're at, to speak their language and connect with them. The other is cultural competence, real deep understanding of the communities, of the resources and the needs, of what's going to work and what isn't going to work. The ability to educate and facilitate. This could be individually or in group settings. And I think it's really important to say that community health workers are professionals. They are not licensed in the way that a physician or a nurse or a physical therapist or a dentist or any other number of roles are, but they nonetheless are professionals who have training, skills, and unique abilities that they bring to the table. Relationship building, we've talked a little bit about, is really critical. And I think very critical, particularly in our experience here at Maine General, is the ability to acquire program-specific knowledge. Community needs are changing all the time, and we're seeing dramatic examples of that in the time of the pandemic. So community health workers need to be able to adjust and flex and to articulate those community needs to healthcare system leadership, because the community health workers are in the community, they're seeing what's happening, and to share that information and knowledge so that services can be adjusted, and that, ultimately down the line, policies can also be adjusted.
On this slide, you're seeing some of the qualities of a community health worker, and they're listed as empathy, resourcefulness, ability to connect, flexibility, as Ann mentioned, creativity, compassion, personal strength, and courage. Also, persistence is a very important thing. When you're trying to reach out to a patient and you don't want to just give it one try and give up. If you're reaching out to them for a certain function, such as smoking cessation, you don't get an answer, or you just keep trying. Make several attempts. A lot of times they'll say they want to get you to get back to them at another date. That's something that you can do, which means that you have to show a little bit of leadership and ability along with that. You got to speak with confidence when you're talking to them. Let them know that you are there to help them, and let them know that you can help them. You have to be dependable and organized. You got to be able to meet them where they are. You've got to either meet them at the practices, or at a food bank, or a public library. Any place that they'd like to meet, you can meet, or you can even meet them in their home if they prefer that. You have to use problem-solving skills like motivational interviewing, which is where you ask a question and not just a yes or no question. You try to get them to give you a little bit more information. Secret sauce, there's no really secret sauce other than you have to really listen to your patient to know what they really need. Let them know that you can help them. It's getting on a one-to-one level with them.
Great, thank you, Mark. Wanted to give you a little context for the work that we've been doing at Maine General with community health workers. So they've been a member of our healthcare team since 2015, and that was part of the State Innovation Model Grant. Some people on the call may be familiar, may have even worked on that, which was a federal grant program. Many states received these grants, and they kind of centered around healthcare transformation. Community health workers at Maine General focused on diabetes, so some of the key standard of care metrics like foot and eye exams, A1Cs, but also things like healthy eating, physical activity, encouraging health behavior change. We also received, we're very lucky to have received 5 years from the Maine Oral Health Funders of support for pediatric oral health and pregnant women oral health work. And support from the Maine Cancer Foundation for colorectal cancer screening work for the at-risk population. And then, as we've been discussing since 2016, work on lung cancer risk reduction.
Okay, the community health worker training, you can see some of the things here on the slide. Some of the major trainings I've already been through, like 6 days of community health worker and core competency training, which is done basically through the Maine Mobile Health. 2 3-hour training sessions with Maine General Medical Center's electronic health records, developing of Maine Lung Cancer Coalition Community Health Worker Lung Cancer Risk Reduction training modules, 8 2-hour sessions on training module specific to your function. And there's also the ongoing support, like team meetings and one-on-ones with your managers, with your teammates, learning new techniques, relating new techniques, things that you can do, things that work, sharing your stories. The support is really, really huge. Then also checking in with primary care practices. That's pretty good too. I mean, it lets them know that you are there as a tool that they can use to relate with their patients.
So as the prevention core of the Maine Lung Cancer Coalition, just a little background for people. Our grant is the Maine Lung Cancer Coalition, as it sounds, is statewide, and it's divided into various core functions, and those cores do different things. So for example, there's an early detection core, a stakeholder engagement and education core. We are the prevention core, and our work over this 4-year time period has essentially fallen into 3 buckets. So the first bucket is community, where we did outreach, education, and developed a social marketing campaign, because we thought it was really critical that the community be engaged in this process and that their voices be heard in the messaging that was developed to be used in various ways. And 2 of those ways were our work with Maine General Practices, who participated in a primary care pilot, and also specialty practices who participated in a research study about annual lung cancer screening. So those are the basic parameters of the work. We're talking about community outreach. This is a picture of the library in Bingham, Maine, where we did have a community outreach event. And, I think it's important to just recognize that this was the only place in Bingham we could find where we could do a public event. And, some of our communities that we're working with are really quite under-resourced, and you have to be creative and flexible and go to what's available. In guiding our work and what communities we were trying to reach out to, we relied on census tract data, which showed us our priority communities based on the high percentages of people who had a high school education or less and who were living in poverty. So we tried to have 75% of our outreach and engagement reach that vulnerable at-risk population, and 25% reach a broader population that those categories didn't necessarily apply to. This is the former Hathaway Shirt Factory in Waterville, and our service area is Kennebec and Somerset counties. And so I think it's important to note that our efforts, although we're part of a statewide coalition, did not encompass the whole state. We focused on the Central Maine service area, and a little bit of demographic information about our service area. So we have high rates of lung cancer, high smoking rates, high rates of chronic disease. We are an older population. Maine, as probably many of you know, is the oldest state in the country, and so our demographic mirrors that trend. And, a lot of the people that we were reaching out to, this older population, they have worked in factories themselves, be more likely to have worked in a factory themselves, and therefore, potentially have more problems and complications with their lung health. So our community outreach really was divided into 3 phases. I'm sure you've heard the slogan, nothing about us without us. So the first thing we did was a discovery phase where community health workers went into the community and met people in settings where they were receiving services and supports and where they were comfortable, where they felt a trusted relationship. And the community health workers introduced themselves to the clients, community members in those settings, and also to the staff who were running the settings, and just kind of said, hey, we're from Maine General, we're working on this lung cancer problem in our communities. This is going to be a 4-year grant. Have you heard anything about it? We had some pens. Who doesn't like to get a pen? That we gave out to people. And it was very low touch, very low key. And then in the second phase, we went back to those same places. So we had established some trusts and some, relationships with the population, and we conducted a survey about people's knowledge, attitudes, and belief around lung cancer. And this was really because we didn't want to develop messages or outreach strategies in a vacuum. We wanted to know what people's beliefs were, where they were coming from, you know, what they thought was important. So we had a survey that addressed kind of what they knew about lung cancer, smoking, environmental risk, had some demographic information in it. And then we used the survey's results to develop messages that were then used in our pilots that we will be describing to you shortly. So we interviewed more than 200 people for the surveys. Now, the quick among you will note that these numbers don't add up to 200, more than 200. And the reason for that is it was a rather lengthy survey, and sometimes people couldn't complete it because maybe we were doing the survey in a line at a food bank and somebody's number got called and they couldn't finish the survey. So these numbers are about 179 people, and you can see it skews female. We think that's probably because women may have been more approachable. Sorry, Mark. And just may have been more willing to, you know, agree to do the survey. So we asked if they thought this was a problem in their communities, and 57% said that lung cancer was a big problem. So good, we're on the same page there. We asked about smoking status, and I just want to point out that the way we did this is we really backed into the smoking question, because what we found in our initial outreach was that people are very defensive about talking about their smoking or tobacco use, and they feel condescended to, they feel lectured. You know, the shoulders really go up immediately. So we had tobacco questions in, but we embedded them later in the survey after we'd asked a lot of other questions and after hopefully we'd gotten this engagement going. So almost 40% of people were current smokers and 32% were former smokers. So again, for the quick math among you, that 72% of people we were talking to were current or former smokers, and that's higher than the state of Maine, where we estimate that 50% of the entire state's population is a current or former smoker. We also wanted to assess their exposure to secondhand smoke. So more than 50% of them were around smoke every day, whether this be in their workplace. Not all workplaces are tobacco-free. Or in their home with family members or even friends. Some people we talked to didn't feel empowered enough if guests were smoking in their home, you know, to ask them not to smoke. So most people around a lot of smoke, either themselves or in their environment, which showed them that the cultural norm was that people smoked, not that people didn't smoke. We also asked about the link between smoking and lung cancer. People were aware of that, and nearly 100% were. So we did take that into consideration when we developed our messages. So in addition to this engagement with the population, we really wanted to connect with people, community-based organizations and state organizations, the Maine CDC, who'd been working on this for far longer than we had and had a lot of expertise and knowledge. And we had 2 requests of this communications advisory group that we formed. One was to help us learn about the messages that were out there around tobacco and environmental risk for lung cancer, and then to identify gaps, what messages weren't out there. So after the survey, we developed messages to use in our pilots, and then we tested those messages in focus groups that were segmented by age, income, and smoking status. And what we found in engaging with the community is that the defensiveness was there around tobacco, but people were far more receptive to messages around protecting their family and the home. So we kind of went with that tacked, and the message on the left, the gray and the green, is about protecting your family and not allowing smoking in your house and addressing some of the environmental risks. So we took that message to focus groups, and then the message on the right is what was developed after the focus group. So in the focus groups, we heard things like, the image on the left looks like an arrow. The colors are depressing. We want the house to look friendly and pretty. And there's no clear there's no clear call to action. So you can see on the right, the colors have changed. Hopefully the house is friendlier. And there's a clear ask, learn how to protect yourself from lung cancer. Call this number. The other thing we found during our survey was that people believed the most effective way to quit was cold turkey. Self-reliance was the way to go. Their uncle, their grandfather did it that way, and that's how they were going to do it. And we know, the evidence is that counseling and medication really dramatically increase people's chances of successfully quitting. So we didn't want to disrespect what they were telling us, though. Like, that was a core belief. We wanted to engage that core belief. So, and we want to try and use a little humor, which, isn't something you see in smoking messaging a lot. But we developed the message on the left: your willpower is strong, like cold turkey isn't always the answer, strengthen your willpower with medication and counseling. So after the focus group testing, this tested really well, the one on the left. People liked the humor, they liked the cold turkey. So we went with the humor a little stronger on the right, cold turkey's for the birds. Your willpower is strong, however, most people need help, and that help is counseling and medication. And this was like a business card size communication piece that people could, put in their wallet, for example.
Okay, we got another poll question. Morgan, if you want to go ahead and open the poll. What are some ways to engage what are some ways to engage a rural at-risk population? Motivational interviewing, taking service into the community, seeking target population feedback, using community health workers, or all of the above. And Anne wanted me to read this poll question because she had a hard time reading it, as I just demonstrated.
That's true.
Again, don't forget to select your answer and hit submit. So it doesn't look like everyone has quite answered the question, but I'll go ahead and end the poll. I think the results kind of speak for itself, but I'll let you guys go over them.
Again, a wicked smart group here today. Everybody got the question right. Yes, all of the above. And I think, this just speaks to when I worked at Maine Quality Counts, Lisa Letourneau always used to say 7 times, 7 ways, before a message is received. And that, you have to go at this in different ways because different things are going to engage different people and inform your work. So that's kind of the what's behind this poll question.
And for primary care pilots, community health workers, and healthcare teams, community health workers will reach out to several places. We'll go to food banks, libraries, church suppers. Those we found to work very well, had a good turnout. And a lot of interest once we were there too, when we met with them personally. We also go to different healthcare facilities. Winthrop Family Medicine was one that I was working with, where they actually gave me an office where I could still be reaching out to patients to see if they wanted to talk to me about quitting smoking. And they also, while I'm there on the premises, any of the providers that had a patient who felt like they wanted to look into it or just wanted more information about quitting, he could bring them right to me while I was there. Also, I'm working with the radiology department currently, where I will reach out to patients who are currently scheduled for lung cancer screening and find out if they are still smoking and if they want to meet with me. directly after their scan to give them information about quitting and see if they'd like me to submit a referral for them for the Maine Tobacco Helpline, which that has been really very successful, and we hope to keep that going, and we get a lot of good responses from it.
So the messaging process that we went through in the earlier slides, one of the ways we used those messages was in our primary care pilot, where we worked with Maine General Practices on reaching people who are at risk for lung cancer and trying to encourage them to take a lung cancer risk reduction. And the criteria we used for the at-risk patients in the practices were people who were 55 to 80 and current or former smokers. And that was largely because that tracked with the eligibility, although not the full eligibility, but some of the eligibility characteristics for lung cancer screening. So we wanted to find out, which workflow or which kind of engagement was the most effective. So we developed 3. One was the proactive practice outreach that Mark was talking a bit about when he's talking about being at Winthrop Family Medicine, where a community health worker was assigned to a practice and worked that list of the at-risk patients and tried to engage people in a lung cancer risk reduction, which we defined as scheduling a shared decision-making appointment in primary care, scheduling a low-dose CT scan, having the scan, having a tobacco cessation discussion, having a referral to the helpline, or testing their homes or mitigating their homes for radon. The other model was a group community outreach model, which you saw the slide of the Bingham Public Library. So in that kind of a setting, we would have a community event that we would advertise and try to promote, put flyers in the community. We had a game with the Wheel of Health. We didn't want it to be didactic and kind of lecturing to people, because I've mentioned how that it was not well received. So we had this Wheel of Health that was very easy to ask people, come up and spin the wheel. You could make jokes about Vanna White, and we would have people answer a question, and the question was all around lung cancer, radon, or smoking. And if they got the right answer, and honestly, even if they didn't most of the time, we would give them a small prize, like a healthy snack, a notepad and a pen, something like that. And then we had a list of people, if they requested, if it seemed like they were really engaged and really were interested in like having a referral to the Maine Tobacco Helpline, connecting with their primary care practice, we would have the community health worker follow up with them, but we didn't require that they register or anything as a condition of playing the game, because we really wanted to engage the community. And the final model that we tried was a shared medical appointment, and under this model, the community health worker worked with the practice and did all the outreach calls to schedule people for the shared medical appointment, which is essentially, a group visit. And then typically that was about 8 to 10 people who would attend, and the medical assistant would collect some key, data points when the patient came to the visit. And then the physician would have a conversation about lung cancer risks and benefits. So the, lung cancer shared decision-making conversation, basically. And then the community health worker will kind of wrap it up with some information about radon and the Maine Tobacco Helpline. And sometimes we had free radon kits available that we would give out to people. Funny story, one person who attended a shared medical appointment at one of our practices, he saw the community health worker, like a month after the visit, and he said, "You cost me $1,200 because he had his home tested for radon. It had really high radon levels, and he put in a mitigation system." So those were the various workflows or approaches that we tested. And our results showed that the most successful were the proactive practice outreach, so the model where the community health worker is assigned to a practice and working with that at-risk list. The group community outreach was very close behind. Most of those risk reductions taken were around radon because, in the community setting, it's very hard to assess age, smoking status, that kind of thing. So those were mostly environmental risk reductions that were taken. Although we did certainly, talk about lung cancer screening and about the Maine Tobacco Helpline and encourage engagement there. And the least successful at, sorry, I haven't been reading these percentages. So 40% of people in the proactive outreach took a lung cancer risk reduction, which we defined as taking at least one action of all those actions I've mentioned. And then 37% of people at the group community outreach events did. And only 7% of people did at the shared medical appointments. And, this really surprised us because going into this work, we really thought that that would be the most successful approach because a lot of our patients are very comfortable with their primary care practices, especially this older demographic. They've been going there for a long time. And we thought, this is going to be great. They're going to be in the environment with the physician they trust and, their peers are going to be there. This is going to be like knock it out of the park. And you can see that it had the least engagement. And we're really not sure why that is. We kind of speculate, but it's just speculation that it could be because people are kind of intimidated about the shared decision-making conversation in a group setting, hearing about the risks and the science and the epidemiology, what's that all about, maybe timid to ask questions or, kind of to make a decision in front of other people. So we're not really sure, but that was the least effective approach of the ones that we tried.
And what you're looking at now is a picture of someone breaking their roof. This actually is something that happened with one of my colleagues. She made plans to go meet this patient at his home, and we'd had a lot of snow the night before, so when she got there, he was raking his roof, and he basically was telling her how he had no time, he was very busy. She had a nice long conversation with him while he was doing it, and found out that, he didn't mind doing things like this because he liked to get outdoors and do things. And after she talked to him for a while, she was getting ready to leave. And he said, if you can give me one reason why I should do anything, what would that be? And she said, well, you said that you like to do things outdoors. You don't make an adjustment or quit smoking, you might not be able to do things outdoors anymore. So right away, that went on to him taking an action. Other things happen too. Like we do learn things from our patients, how to, rebut against something. I had a patient tell me that she agreed to meet with me for smoking cessation. And so when we met, she was really glad to see me. She was glad I offered. She said she's tried many times to quit and hasn't been successful, but she's going to keep trying until she is successful. And the reason that is one of the things that she always told someone who said, you really should quit smoking. Well, she always told them, but I enjoy smoking so much. Well, that person asked her a question and it stuck with her, and that's why she keeps trying, is if you like smoking so much, would you recommend it to your children? And that's something I've used myself, that particular line when I talk to someone who does say something like that to me. If I feel it's a fitting thing to say, I will tell them. And even if they don't take an action, you've planted the seed so that, they will think about it and maybe take an action in the future. And that, actually moves on to, how we go about doing these things, how we engage with them. As I said, motivational interviewing is a very key thing. You can get so much information from a patient when you ask them a questions where they do have to give you a little bit of information, and they're more than willing to tell you about themselves too when you do. You need to reach patients in a variety of ways. You can, whether you're calling them on the phone or you're visiting them at home or after a scan and radiology, as we do also. You have to meet them where they are. If they're not comfortable meeting with you, even if it's at the hospital or their doctor's office, you can always offer, well, we could meet in a public place if you're more comfortable, have a cup of coffee, if you're considering that. And again, even if the answer is no, you're planting the seed. You give them your information to get back to you if they decide they want to. Some instances, they may pop up on another list for something else, but it's still related to taking in lung cancer risk reduction. And if you call them back later on again, even if you haven't heard from them. It's just another opportunity. And, you've already planted the seed. If they say yes, yes. If they say no, they mean no. So, and you don't pursue it, but you just let them know that you're there to help if they need it.
So we're kind of moving through the timeline of our work with the Maine Lung Cancer Coalition. So year 1 was really the community engagement, year 2, the primary care pilot, and years 3 and 4, the primary care pilot and an annual reminder research study that we worked with Dr. Corson on. And we wanted to address this research question, whether community health workers support addressing barriers to annual lung cancer screening would result in an increased number of patients who receive the screening as per the recommended standard of care. And this is a problem in Maine and in our healthcare system and nationally, that people come in for their baseline scan, but they don't return for their annual as is recommended until people age out of the screening or they have a health condition that would make the screening kind of counterproductive. So it's not really in the culture yet in terms of both the public and the patients and the providers around the annual part like it is for mammograms. So to have this research study, I just have to say that the teamwork, I know it's a bit of a cliche, but it truly was very critical to the work. We couldn't have done this research study without the collaboration from our department, Prevention and Healthy Living, the radiology department, the cancer center, the pulmonology, thoracic surgeons, the primary care providers, and the navigators at the cancer center, who really all extended themselves to us and worked as a team to address this. We had 2 components. We had the research study, and we also had tobacco cessation at the point of care, so after the scan, as Mark has referenced. I want to briefly show you this workflow. This is the workflow for the research study, and not so you can read the little boxes because I know they're too small, but just to say how we used workflows in this project. And one was to define what our problem was, what we were trying to work on. The other was, what are the roles and responsibilities? This is different colors because it's different entities or individuals' role or responsibility to do something in this flow chart. And finally, in quality improvement. So we developed the workflow, and then in a couple weeks or a month, we would look at it again. How is the work going? What did we need to adjust? So for the annual reminder pilot, we had a list of patients who were 13 months or more overdue for their scan and who were lung RADS 1 or 2, so on the lower scale of the seriousness. And we divided that list into 2 groups. So one group got a passive reminder letter, hey, you're due, please call this number. The other group got that same letter, but also outreach from Mark about the importance of having their low-dose CT scan and removing barriers. And you can see that about 20% of the control group ended up completing a lung cancer screening compared to 86% of the intervention group. So people who had the letter and the community health worker outreach. And the main barrier that Mark found was that, was that connection. In our system, primary care enters the lung cancer screening order, which must be entered. It's not a standing order, so it must be entered with every scan. And he did a lot of work reaching out to primary care, finding the right person, connecting the patient, primary care, and the specialty practice. One secondary outcome that we had was trying to connect people who were smokers with the Maine Tobacco Helpline. And in the intervention group, so people that got the letter and the community health worker outreach, there were 37 current smokers. And of those 37 people, 13 of them agreed to meet with Mark. And of those 13, 8 people accepted referral to the Maine Tobacco Helpline. That's a very high acceptance rate kind of in the field. So concurrent with the research project, but not part of the research project, we reached out to people who were scheduled for their lung cancer screening, whether it was their baseline or their annual. Mark got a Sorian report every morning about people who were scheduled. That's our billing and scheduling system for Maine General. And he would call them and say, hey, you know, would they be interested in talking to him following their scan? It's a very quick scan. So, you know, this was a very easy thing for them. They didn't have to go anywhere. They didn't have to make a phone call. So he reached out to more than wants me to make sure I say that it's more than 344 people he reached out to, but there were 344 people who were using tobacco. And of those 344 people, 215 agreed to meet with him and have the counseling. And of that 215, 151 accepted referral to the Maine Tobacco Helpline. Again, that's a very high acceptance rate of the referral in the field. And, you know, we think that really speaks to the power of the community health worker to make that connection in a non-judgmental way.
And we have another poll question for you. Morgan, if you want to go ahead and open the poll. If a facility offers low-dose CT lung cancer screening, how do you offer patients tobacco treatment at the point of contact at the screening? Referral to Maine Tobacco Helpline via printed material? Referral offered by primary care or referral to primary care? Direct referral to Maine Tobacco Helpline or other? We'll give you a few seconds to answer that.
Just a few more seconds. Don't forget to select your answer and hit submit. All right, I'm going to go ahead and end the poll, and you should see the results now.
Yeah, so we have 23% offer that's at the point of contact screening, 8% via printed material to the helpline, 31% to primary care either way, and then direct referral 15%, and then we have a pretty high percentage in an other category. So that's really interesting, you know, that there's lots of different ways that are happening out there that people are using.
In this slide, this is a picture of me with one of the technicians at radiology department in front of one of the CAT scan machines, which I meet with the patients after they've been scanned. And, you know, I reach out to them first, make sure they want to, and then I'll meet them after the scan to talk to them. And sometimes something really good happens. I had an instance where a gentleman agreed to meet with me, and his biggest drawback was that, well, it's hard for him to try to quit because his wife still smokes. And so I asked if she had thought about it, and he says, yeah, she's out in the waiting room. I said, if you'd like, I can talk to her as well. And he said, yeah, that would be great. She's been thinking about it. So he went out and brought his wife in. I spoke to the both of them about, you know, the benefits of quitting smoking and, you know, what they can do, and offered to submit referrals for both of them. And both of them wanted me to submit referrals to the Maine Tobacco Helpline. So it was two actions. Just in planning on meeting one person, I ended up meeting two. And at the same time, I got two people to take an action to reduce their risk of lung cancer. So it was that was a bonus one. I kind of like that. But that doesn't happen all the time. It seldom does. But just to let you know that people do think about it. People who smoke, I'm a former smoker. I know what it's like. You know, when someone lights up, it smells good. It's an easy thing to think that. But, you know, you learn to distract yourself. And you can relate all these things, being someone who's been there. And I think that says a lot for the work that we do, you know, being able to relate with them.
So this is you know, I hope that you're convinced of the values of community health workers within a healthcare system, and this presentation has showed you that. I can see we're running short on time, so I'll just kind of quickly summarize the key points from this wonderful statement from one of our key stakeholders, Dr. Beth Leichling, who's a medical director at Oakland Family Medicine. And she talked about how community health worker outreach saved a life, got people into her practice that she hadn't seen in a while, and was finally suddenly like getting a superpower because her visits are very short, and this gave time to address questions, logistics, and provide support. I want to briefly talk about COVID because it's inescapable and has affected all of our work. Just to say that one silver lining is that the Department of Homeland Security issued guidance on March 19th that declared community health workers part of the essential health infrastructure in the COVID response. And our experience with COVID, particularly related to community health worker and Mark's work, is we suspended low-dose CT scans on March 20th in accordance from guidance from US CDC and American College of Radiology. You can see the impact that would have had on the work Mark has been doing. We have started those on May 1, they've started up again, so he is able to do that point of contact screening. We also developed a COVID and lung cancer workflow where prior to the low-dose CTs resuming, where Mark was reaching out to people who are overdue for their scan, talking about the importance of lung health, the increased risk COVID would pose to someone for complications with weakened lungs, and trying to get the tobacco referral. And that, you know, even though we weren't doing scans at the moment, that it's very important and we'd be back in touch with them. So Jessica and Morgan, I know we're getting short on time. Do you want to skip this poll question and have me go?
I can open it real quick and folks can answer. Because this is the last slide and we don't quite have any questions yet. So
Okay.
If you guys want to go ahead and answer this last poll, and while you're answering this poll, if you have any questions, feel free to put them in the chat so that we can start addressing them in just a few minutes.
And the poll question is, if your organization does not already employ community health workers, do you have any plans to do so in the future?
All right, so we didn't have a lot of answers yet, but I'll go ahead and end the polling and share the results with you.
So we have about a 60-40 split, 60 yes, they'd like to do so in the future, and 40 no. And I just want to thank everybody for participating in this webinar. This takes us to questions if we have time for that, Jessica. And if not, we'd be happy to follow up with people.
Yes, we do, Anne and Mark. Thank you so much. That was absolutely fantastic and great to hear all the wonderful work that you all have been doing. And thank you for taking the time to put this together and join us today. It's really been exceptional. Thank you so much. So we do have a question in the chat box, and we do have some time we have about 6 minutes left, so we have some time, nice time for questions. And so the question was, what was the acceptance of CHWs by practice teams in the primary care settings? Which is a great question. So again, what was the acceptance of CHWs by the practice teams in primary care settings?
You know, I think that varied quite a bit. You've seen the quote in the presentation from Dr. Leichling, who was kind of over the moon about community health workers. I think there's other practices and, you know, providers within those settings that, you know, need more information. They need education about what a community health worker is. We needed to provide some education around the fact that community health workers are employees, that they're trained in all the same privacy and HIPAA protections as every other main general employee, that they do have the electronic health record training. So I think it's really kind of a conversation back and forth, you know, with primary care providers. And we're really trying to standardize our community health worker work at Maine General and have community health workers assigned in practices. And I think, you know, as that relationship is built, that it'll just become a, you know, a stronger and stronger relationship.
Absolutely. Any other questions in the chat right now? If not, I do also have a question. So in talking about barriers, like you had mentioned, both of you in regards to, you know, again, getting the annual baseline, I mean, you know, getting that baseline and then bringing people back in for that annual, right? That's seems to be a bit of a challenge. So when you mentioned, you know, the biggest barrier, but could you maybe talk about, you know, Mark, maybe some of the other barriers, and Anne, that you've, you know, what are some of the things that maybe patients tell you why they haven't come back for their annual exam?
That's a really good question.
Like, is it lack of time? Do you know what I'm saying? Do they
Well,
say,
I'm just going to say that time is one of the key factors too. A lot of
yeah,
people have always got so much to do, but the biggest factor in all really is just that a lot of them don't even know that it's an annual. That they've had their baseline, they don't know it's an annual. So it's a matter of just reminding them. And if you're not familiar with it being an annual or being told you that way, I'd be happy to get you in touch with your provider to have a discussion with them to see if they think it's something that's necessary. And they will tell them that it is, of course, because it is an annual screening.
that's a great point. I think that that really folds into the quality improvement aspect of this, which folds into your work, and you're nodding, I can see. With you, I think the fact that you did the control where you had just the letter, right? And then you had the letter and the call from Mark, and the huge difference, that you had in that follow-up from patients. I think that that's really important. And I've seen that in other projects and work, having that personal touch obviously showed that that was incredibly impactful. And it shows that in this work, that's, another level of importance, because people don't or may not remember, right? We know time passes and we try to remember everything we can, but right, for patients to know that this is annual. So I think, this just on a couple different levels shows the importance of follow-up, outreach, right? Pulling those lists, making sure that you're being proactive with that outreach and reminders. Yeah, excellent. Great. Any other questions for Mark and Ann? We have a couple minutes left. Oh, we have another one. Do you feel that a CHW working on tobacco cessation has to have had experience as a smoker? Good question.
It helps. It helps a lot. I know when I was a smoker and my doctor would tell me, you better think about quitting smoking. My whole thought was, well, here's just another person who's a non-smoker who wants to tell me what to do. But being someone who's been through experiences, not only in quitting smoking, but how smoking has affected my life in a negative way in so many aspects, losing my wife to lung cancer and still smoking, I let them know how addicted I was. And I think it has a big deal to do with how you can connect with that person. You have the experience. They know that you know what they're going through. So yeah, it does. It does help.
Great. Thank you so much, Mark. I think that's it for questions for now. Again, if there's any other questions, we're just going to kind of wrap up here. We have about a minute left. If there are any other questions, again, feel free. We're going to just a second go through some contact information so that you can feel free to reach out with any questions you may have after the fact. And I also want to mention that we also have the evaluation in order to obtain the CME. You'll see that link in the chat box. So feel free to click on that link or copy and paste that into your browser. So Anne, if you can advance the slides. So again, just to remind for contacts, you can go back one more, Anne, to that's right, your contact. That would be great. So again, this is Anne and Mark who have kindly given us their contact information and truly mean this. And I can say this as I work with them, within the Maine Lung Cancer Coalition. They're happy to talk with you both about this presentation and any of the questions that you may have. So again, do not hesitate to reach out to them. The next slide is the Qualidigm team contacts to help bring on this webinar today. Again, our contact information there. If you have any questions or any issues with the CMEs, again, please reach out to us and let us know. And also here's just where you can follow us on social media. And then again, on behalf of the Maine Lung Cancer Coalition, we thank you so much. And again, as Anne aptly said at the beginning, for joining us on this beautiful day and spending your lunchtime with us. We hope that you found this very educational and really opened your world and eyes around lung cancer screening and really incorporating the community health worker within this work, and what a tremendous impact that you've had, Mark, and Anne, as being the lead with all this work as well. So again, huge thank you to Mark and Anne. Thank you so much for joining us. And again, thank you, everyone. Have a wonderful day.
Bye.
Thank you for having us.